Well, good afternoon, everybody, and thank you for joining us. You've landed at the CAF COVID Weekly Roundup. My name's Jason Beldman. I'm the Director of Emergency Preparedness for CAF, and today is May 7th, 2021, and sadly, we're not going to be reviewing AFLs. We really thought that we would be discussing the differences between the CMS QSOs and the AFLs at this point, but they have not been released. I anticipate they'll be released very soon, but of course I've been saying that for over a week now and it still hasn't arrived. I apologize. I don't have any control over that, guys, and that applies for both the ICFs and the skilled nursing facilities as well. So if you came to tune into the update for the AFL, sadly, I don't have anything more to add from what we talked about last week. So I wanted to pivot and talk about the CMS QSO that came out in regards to the emergency preparedness requirements. So if you're, if you were looking for COVID related stuff, this is only tangentially related to COVID, but there's a lot of things within this new CMS QSO that came out at the end of March, and we're gonna dive into that. So hopefully you guys we'll take notes copiously here, and we'll record this version. It'll be available on YouTube after sometime in the next few days. We'll get it uploaded. And there's a couple of handouts that go with today's presentation. One's a crosswalk from Asper Tracy on all of the emergency preparedness requirements, and the other one's the CMS QSO. All right, I'm gonna hop to our regular preamble. And Patty, I don't believe is going to join us today. We're going to specifically concentrate on this this one QSO, so and probably will not refer to the AFLs today. So as an introduction, the speaker's opinions expressed are their own. They may not reflect CAF's official position. This is a part of a grant-funded program, and I have no personal financial conflicts. The intent of the webinars is to give you a situational report of what's happening in the world of COVID for our buildings, as well as forecasting and best practices where we can identify those. All right, so I want to hop to the emergency preparedness requirements. These are in effect now. It's important to note that there are no new deficiencies, but they vastly expanded the definitions in some of the requirements. And when I talk about these definitions, there's an interpretive guidance that the surveyors use, and that's in that QSO. And it explains how the surveyor should be looking at specific types of tags to ensure compliance. And they've really expanded on some of that. And I'm gonna go over where they've expanded, and if you guys have questions with this is some really kind of, I don't know, it's dry information, so, and it's a lot of it. So if you feel uncomfortable with the information we've presented here, I'll probably present them again later on this year, but if you want something more personal, please don't hesitate to reach out and give me a call. All right, so let's talk about the first major change that happened, and that's expanded surveyor guidance on potential deficiencies surrounding alternate sources of energy. For all SNFs, that's going to be your generator. If you're an ICF facility, that could be like a portable generator or whatever your plans are to provide alternate sources of energy if you lose power, have a utility failure. One of the real highlights here I want to point out is if your facility was initially certified after October 1, 1990, you need to have that, well, you should have your certification date on the front of your plan no matter what. But if you've been certified after 1990, there's language within the Federal Register that requires all skilled nursing facilities to maintain a safe temperature range, or safe and comfortable temperature range of 71 to 81 degrees. So your plan is going to have to incorporate how you're going to maintain those temperatures. And they have a little description of what a procedure would look like if in order for you to kind of monitor those those temperature ranges, and I'll go over those in a second, but that's important. You got to have your certification date on the front of the plan. That's new information. It hasn't been required before. Super easy for them to give you a deficiency if it's not listed on the plan. So make sure that's on there. That's on the E15 tag. It went on to stay under the E15 tag that, and this goes for anybody using a portable generator. If you have a portable generator, it must be connected via transfer switch, a permanently installed transfer switch. It cannot just be run through by extension cord into the home. If a facility has a permanent generator, so we're pivoting back to the SNFs, the skilled nursing facilities that have either added a new generator or have been constructed after 2010. In NFPA 110, there are requirements that you maintain 96 hours of fuel on site if you are in an area with potential seismic activity. And for us in California, that means virtually the entire state. So if you have remodeled or installed a new generator from 2010, January 1, 2010 and above, you would fall under those NFPA 110 provisions, and that would require you to maintain 96 hours of fuel on site. If your generator is prior to that range, there is no, well, there's a state minimum of 6 hours that all of us have to do, but there's flexibility within that amount of time, and the flexibility is built on how easy it is for you to be able to maintain a safe condition of care or safe space until you can evacuate. Now, that's not best practice. Best practice, we want to encourage everybody to have not only 96 hours, but have a process to be resupplied with fuel in the event 96 hours is not enough. And in the case of an earthquake or a large natural disaster, 4 days is really cutting it close, and it may take longer than that to get you resources. So 96 hours is where we want to ballpark ourselves, even if we weren't before 2010. I think most of you guys are really close to that. But if that presents an issue or storage challenges, I want to hear about that from you guys, and maybe if you found a way to a best practice around that. If there's other things that we're not considering that you guys are doing, I'd love to hear that. In terms of inpatient providers, each one of us must have a policy and procedure that addresses food, water, medical needs. That's not new, but I wanted to highlight this because in the CMS EP regs, it really highlights the fact that both staff and patients have to be countered in this with these resources. So we need food, water, and medical and pharmaceutical supplies to meet the needs of both staff and patients that are going to be sheltered in place during an emergency. So not huge changes, but definitely some focus on one, those that were certified after 1990 to maintain that safe temperature range, and two, those that had generators after 2010 to make sure they have 96 hours of fuel on site. All right, we'll hop to the next section that really expanded on the exercise requirement. So this is added new definitions of acceptable testing exercises, and that's under the E39 tag. This actually is a little bit of a help to us, or I don't want to say a help, but it is expanded what we can use for exercises. So before, they did not use mock disaster drills or workshops as an allowable form of exercise. Now they have not only allowed those, but they've given language specifically to what those kind of drills would look like. So if you're interested in that CMS QSO that is in the handouts, you could just do a Control F and search for mock disaster drill. There's a paragraph in there that describes what that looks like. Same with the workshop as well. These are much easier for you guys to do rather than a full scale or a functional exercise or a tabletop exercise. The handwritten kind of formatting that goes into the development of those is much less involved than in a tabletop or a full scale. So they may be easier for you to accomplish on your own. And it may allow us to do some other more creative things to exercise our plans, like things we can do virtually. And I really think we can kind of pivot to this virtual workshop to be able to meet one of those exercise requirements. So that's good news for us. The bad news is we will always have at least one exercise requirement annually, even if we're activated in a emergency response. It went on, there's many kind of language in there to point the surveyor to say, you have to not only have the process to deal with the disaster, but have a process to deal with a planning process to deal with a multitude of things happening at once. So now when it comes to exercises, generally the state of California every year does a statewide medical health exercise. The people that do that statewide medical health exercise have been activated, and they're the responders during these events. And so last year and this year are both going to be canceled. Last year was canceled. This year is going to be canceled. Most healthcare coalitions throughout the state participate in that statewide medical health exercise, and that's our gateway into having an exercise prepared and planned for us, where we're just participants. Now, I'm not sure that any healthcare coalition is going to have an exercise either this year. So that really means that one of these exercises, full scale, functional, mock disaster drill, tabletop, or workshop, we're going to be responsible for doing in 2021. Now, if you have questions about how to do a tabletop exercise, or you want to create your own tabletop exercise, there's tons of formats out there that will walk you through the creation of doing your own. We created a 15-minute training video on how to create your own tabletop exercise with some, B-roll footage of what it looks like when you guys are going through the planning process for that. And then we also have a number of exercise samples. If you just want something that's already pre-written, that's got the scenario in there, it's got the injects in there and things like that, you can download some of those. This is something we update quite frequently as we learn more about response and different disasters. We change scenarios to make them more realistic. So check back with that site frequently. All right, the next kind of clarification was around what kind of documentation is required for you to maintain. And one of the crystal clear things under E1 is now there's language that was added in there that gives surveyors the authority to cite IJs for EP related issues. In that, it doesn't say for just E-tag number 1, but under that E-tag in the description of it, it clearly gives the surveyors the opportunity to be able to do that now. I don't think it would happen under this tag. It might be happen under other tags, but they do have the opportunity to do that now. The E number 1 definitely requires annual updates of your emergency plan. So you need to have somewhere at the front of your plan with a log that shows each thing that was updated, when it was updated, who updated it, and what was the nature of the update. If you're using our EOP template, we have a checklist that has where in the template each one of these tags is covered inside the template. It also has a section within there for you to kind of initial or put the dates in which you change things. And then you'll have to type in your own kind of description of how you changed the hazard. All documents need to be maintained for at least 2 years. And it goes on to talk about, point the surveyor to what kind of documentation they should be looking at. In terms of planning for EID, this is where the big changes happen. And they didn't write new tags for these, but they vastly expanded the definitions within ETAG 004. So in your hazard vulnerability assessment, and I didn't put a link there, but there, Kaiser, we traditionally in healthcare, most facilities use the Kaiser HVA form to do their facility assessment. Kaiser released a new form, and I'm uploading that to the website today. But if you go to cafdisasterprep.com/HVA, you can download the HVA form. The new Kaiser form has EID on it. If you're still using the old 2017 version, I do not think it has EID on there. And EID just stands for Emerging Infectious Diseases. It goes on to state that throughout the development of your emergency preparedness program, your IPs should be involved in the planning and development and revision, not only to the EID policies and procedures, but to the plan in general. So I would assume that during survey, there's such a focus on this that you can expect the surveyor to query your IP to ask them what their involvement was in the development and revision and annual updates to your plan, not just the EID plan, but the plan in general. It really encourages folks to engage and coordinate with their healthcare systems and healthcare coalitions. For us, in most of, well, I don't say most, but there's a number of these tags that really point to that collaborative work with outside agencies. Most of that can be accomplished by frequent attendance with our healthcare coalitions. Now, it doesn't mean that by going to a healthcare coalition meeting, you're going to get signed up for bed polling and you're going to do all this at that one thing. But it will give you access to all the people that you need to be collaborating with. So local public health, local OES, other healthcare facilities, all of those folks are supposed to meet in that one kind of group to discuss those issues. It goes on to expand what their expectation is for you to document essential services and continuity of care. So the whole genesis of the EP requirements is to really identify the risks that are most impactful or most likely to impact us, and then to determine how can we continue care despite that disaster. And so that's all got to be planned out before you think of it, and you really have to look at your entire building and figure out what is an essential service and what can be removed during a disaster, or what does it need to be done during a disaster. Essential services are things like utility, or power, water, pharmaceutical supplies, food, essential heating and cooling. A lot of those things are all in essential services. What are our plans for continuing care when we lose those essential services? We'll need to demonstrate that we have agreements or contracts to reestablish those essential services or mitigate them during an emergency. So an example of this would be you have a contract with a fuel vendor to bring you diesel fuel in the event of a power outage as you get closer to running out of fuel. So that's an example of an agreement or a contract they're going to want to review. If you have contracts or agreements with staffing agencies, all of those things would fall under this deficiencies. Facilities also need to include planning and revisions of existing plans and contracts of an inventory of supply needs, PPE, critical care equipment, and transportation. Transportation is a huge one. We're not talking about it in infectious diseases necessarily, because it's not that hard to move folks around outside of the infection prevention stuff. But in a fire or an earthquake, transportation is incredibly difficult to obtain in a timely manner. So those are important to have that planned out, and you'll need to be able to demonstrate that you have arrangements or agreements and contracts with folks to provide those services should you lose the ability to do that. In terms of expanded guidance for surge planning, and this falls under the E006, this is more on emergent infectious diseases, but they want in that risk assessment, it has to be both a facility-based risk assessment and a community-based risk assessment combined together to make a complete risk assessment. So your healthcare coalitions do HVAs every year. The first quarter of the year, each healthcare coalition does an HVA. And they're going to ask you to submit your HVA, which will contribute to an overall HVA for the community. And then those folks generally will pass that out to all the providers, and then you can keep that for your records. The whole point of quantifying where our risks are is that we will develop policies and procedures to maintain the continuity of operations based on the risks that we're most likely to face. And there are certain things that will always stay: evacuation and shelter in place. Regardless of the disaster, those are two of the things 100% we need policies and procedures on, because those are the outcomes most likely from any type of disaster. Like I said, we're going to need to identify all essential functions, identify all the risks on your HVA, all contingencies that you have, assess the extent of emergencies which may cease operations, and demonstrate those MOUs. All right. Next section on surge planning, more surge planning, expanded E07. And this has to do with what our roles and responsibilities are during disasters. Now, some folks use incident command and some folks don't use incident command. Whoever is identified as fulfilling a role in your emergency plan, whether it's listed out with a role like the DON will do this or the incident commander will do this. If you put the incident commander in there, you're going to have to name the staffs that are going to fulfill that role. And whoever is listed in these roles, that should be the genesis of their training. Whatever pre-identified role they're going to be expected to play during a disaster needs to be a part of their annual training for emergency preparedness. So if you have an incident commander, that person should be taking or should be doing some annual training on incident command and what it's like to manage during disaster. Whereas an IP person, maybe they're looking at their role as a planning chief, and so they would review the roles and responsibilities of planning chief. Those are kind of examples of how you could do your training to match the role they're expected to play. That's really helps promote that kind of resilience in our staff. We'll need to document that patient needs that cannot be addressed by any in-house service in emergency would be met with the use of just-in-time contracts or emergency transfers. Surveyors are going to ask how your plan addresses any services that cannot be provided in order to maintain that continuity of care. And expect the surveyors, let's say you have a person's name designated as a role, they're probably going to find that staff member and they're going to ask them, have they been trained on those roles? And maybe ask them questions about what are some of the functions of that role in a disaster. We also want to do in our exercises, when we do a tabletop exercise or a full scale or a functional exercise or a mock disaster drill, we want to do those in a manner in which the people that would fulfill that role are fulfilling that role during the exercise. Now that's a best practice. It's not written into there, but really as a resiliency thing, the best thing I could tell you to do is if they exercise that role a few times, they'll be much more comfortable than if they are just handed a job action sheet and say, here you go. So surveyors will also be verifying that delegations of authority are written out in your plan. In other words, let's say you say the administrators, the incident commander will always be the incident commander. What happens if the administrator is injured or is affected by the disaster and they cannot complete their service? Who are the backups to these roles? So that needs to be quantified and put in there. Obviously, we want to let the people know if they're going to be a delegate or they're part of our succession plan. They should be trained on that as well. We want to expand guidance and best practices related to reporting of facility needs. That's frequently come across, but this really has to do with what is our, well, we want to keep documentation of our process to collaborate across the spectrum. And that, you know, it's not that hard to demonstrate that we're doing daily bed polling right now, but we need to have that capability to respond to requests for information from both local health departments and our licensing agency. Some of these things can be accomplished with regular attendance at the Healthcare Coalition meetings. Just with everything else, you're going to keep documentation in that meeting. The meetings, I said this before, it goes beyond just attending. It's a mutual aid network. And if you look at that, this is your network of folks that can assist you during times of crisis, all across the board, both up and down. And it's not just what can we get from them, but it's what we can, how we can help them help our citizenry, right? We want to not only just be a taker, but we want to make ourselves available without compromising, obviously, the health and safety of our residents and staff. And we need to have a documented process of how we share information and obtain information from those emergency contacts. All right, I'm gonna kind of rapid fire through some of these other ones because they weren't huge changes, but they definitely were changes that you'll have to accommodate somewhere in there. In terms of the tag E18, this is a requirement to track staff and residents throughout a disaster. The main point here or difference here, this is a standing requirement. Anytime you evacuate, you need to keep track of both the staff and resident wherever they go. So if you're doing that through an electronic process, let's say you've taken evacuees and you have staff from another facility working in your building and they're using your time clock to log in, or they're using another electronic means to kind of document where they are at what time. If those electronic systems are not functional, you need to have some kind of secondary system in the event of a power failure. There, we have a paper tracking form that's available on our website. You could just do a resident tracking form, and you can download that. I think there's one on staff tracking. I know we were going to update it, and I'm not sure if it's up on the website, but frankly, it's the same as the resident tracking form. We just removed the term resident and replaced it with staff, but it's a pretty, it's not very detailed. It's just kind of a time-based log of where somebody is and when they got there. So in terms of the clarifications under E20, that's the evacuation requirement. It added in this this kind of language that in our policies and procedures, we should have procedures that address what to do if a resident refuses to evacuate, even if their life's in danger. I was taken kind of aback from this. I've not run into anybody that said they're not willing to evacuate if the building's on fire, but I think this is more born out of kind of resident movement during an EID. And so, you know, that's not technically, you know, I guess it's evacuation, but really, I think that's more patient movement. But you're going to really have to, you know, talk with your staff of how you would deal with that and add language into your procedure for that. I'll talk to Deanne to see if we can create some language around that, or maybe we could talk to some other providers about best practice of how to do that. I know there's recommendations in the QSO as to, you know, best practices, and it has some links to some other stuff. I didn't find it as helpful as I would like in terms of, you know, suggestions for what we should do if somebody refuses to evacuate. But I do know this, it was very clear at the bottom of the thing in the surveyor guidance. It tells the surveyors to ask what your process is when a resident refuses to evacuate. So expect that question to be asked on your survey. There's more huge focus on the surge planning. This has to do, the E24 is more regards to staffing shortages and volunteer usage during disasters. So surveyors are going to be asking what are your staffing strategies to deal with staff callouts and things like that, and what is your plan to use volunteers during disaster? Do you plan to use them? If you do, where's your volunteer policy and procedure? Anyways, we have they're going to really hone in on your policies and procedures during emerging infectious diseases. There's going to be a ton of questions about that, so be prepared to deal with that. I think you guys are probably real comfortable with that at this point, and frankly, that's a part of your plan you could probably explain better than any other part of your plan to a surveyor, but just be prepared. They're going to ask a lot of questions about that. In terms of transfer agreements during disasters, this is not a new requirement. This has always been required, but I just want to highlight that they're encouraging providers. It's not enough to have one or two MOUs. You have to have multiple MOUs with multiple providers. Our suggestion is to have a handful that are close to you and have a handful that are farther away from you. If we're in a large natural disaster, chances are those folks that are close to you may be operationally impacted, and they would have limited ability to assist you. So we want to encourage you to have MOUs with providers that are outside your general geographic area. Now, if you're in San Mateo County, you're not going to reach out to folks in LA, but you may reach out to folks in Solano County or Napa County or something like that, where they're not out of your mutual aid region, but they are far enough away that it's unlikely they would be impacted by the same natural disaster. Now with EIDs, everybody's impacted, or pandemics, everybody's going to be impacted, obviously. So some of that's going to be dependent on what the disaster is. These MOUs, their suggestion in there, and we've seen this cited a lot, and I think that citations were based on, there was not a lot of clarity within the requirement for MOUs, that your MOUs should be updated at any cadence. They've changed that, and they've added language in that said, along with your plan, your MOUs should undergo annual revision to see if they're still applicable. So that would be, coordinating with those other folks that are on that, that you have those agreements with, to see, one, is the administrator still there? Is it still a reliable MOU? And then the surveyors are going to also ask about transportation arrangements, so MOUs with your transportation providers, along with those agreements with other facilities. All right, we're going to talk about alternate care sites and 1135 waivers. Generally, we don't do a ton of this. Obviously, if there's an 1135 waiver that's done by the state for all of us, we're going to incorporate that. But by and large, we're not going to apply for 1130 waivers on our own at a provider level. You can do it. There's nothing against that. But really, this tag more points to, it's kind of an alternate care site is a term that we kind of confuse. We can have an alternate care site within our own facility to provide care in an alternate setting. So I know a lot of you guys have had, or you created like an intake, or you converted an open space into your transition or your quarantine area or things like that. That would be an example of setting up an alternate care site within your own setting. So, but there's also alternate care sites that are not pre-planned. Things like, folks that evacuate during a wildfire and they go to a collection point. Maybe it's a public evacuation site, and they stage there in order for them to determine where they can get the residents into actual beds and actual facilities. Until that time is met, though, we need to have considerations of how we will maintain that kind of continuity of care, even if we move to an alternate care site. So we need to think about, well, what's our patient population? What do we need? What supplies do we need to take with us? What equipment do we need to take with us? And what staffing do we need to take with us? As well as, is the environment that we're going to safe to house these folks? So all that needs to be thought out. If you're going to use a staging area as a part of your evacuation plan with your communities, and it's something we highly recommend. I know a lot of that relies on the community fulfilling a really big role of identifying these sites, letting you know where they are. We'll work on advocating on that side for the response communities to better identify those. But as a best practice, during these wildfires that spring up that move so darn fast, we cannot take the time to figure out where to put people in beds if we've got an hour to get out of the building. We don't have universal bed polling across the state, so we don't have the ability to access those beds very quickly. And then you talk about the transportation issue of having to move people that are non-mobile into maybe across county lines and things like that. So it's really important for us to kind of think about, if we have to evacuate at a moment's notice, is there a safe spot that we can go to in order to get our bearings to get folks into the right environment? This really encourages that collaboration with those local officials. Like I said, your local OES generally attends those healthcare coalition meetings. It's always the case, but they're a part of that continuum. That will help you kind of determine where those collection points are. And if you plan to have an alternate care site on your campus, let's say you're an RCFB or a CCRC, and you have other spaces within your campus that are not licensed skilled nursing spaces, that is, but it could be a safe space to treat folks. Certainly in an EID, that's a fantastic kind of plan. I frankly don't see why we don't see more of that in the CCRC communities. And I think that's the folks on the licensing side, on the assisted living side, don't want skilled nursing folks crossing over or utilizing other spaces that should be for that licensed service. So that we've had some problems kind of get those approved, but it is definitely far and away, I think, the safest way for you to kind of plan how to do an alternate care site. All right, clarifications on E34. This is our ability to share our occupancy needs with outside agencies, and it greatly expands what is expected of you in situational reports and bed polls. If you are in Los Angeles County, you're going to want to get signed up on ReadyNet. If you're in another county, it depends on the county. All the ReadyNet's in most counties, but there's EM Resource, there's Live Process. There's a couple of different technology platforms that different counties use. Whatever that technology platform is for bed polling and situational reporting, you guys need to be involved in that. Every single SNF in the state should be involved in those, whatever that process is to engage with that the MOOC program. And the MOOC program sends out those or requests those situational reports. It's not only the MOOC program that we need to be able to respond to those situational reports. It's licensing, it's local health departments, it's NHSN at a national level. So all of that is expanded upon your requirements. So you're going to have to write out how you engage with those agencies and how you provide situational reports and respond to bed polls. In terms of the clarifications on training and testing of staff, none of this is new. I just want to review kind of best practice because they highlighted it in the update to the surveyors. So we know the surveyors are going to be asking or querying about these things specifically. Your training program needs to be reviewed annually to make sure it's still training the applicable things to the applicable people. That training program is not just, that's part of the next tag, but It's upon hire, so it's onboarding training, and then it's annually. And your facility risks, whatever risks that you have identified as the most impactful for your building, should be the ones that you concentrate on in your training program. So if you do an exercise or something like that, it's great to say, look, we've identified, wildfire as our #1 risk, and we did a tabletop exercise, and in our training program, the incident commander and all the command staff are going to do incident command training on what to do in a wildfire response. That would be a perfect example. That's the kind of stuff that the surveyors are going to look at. In terms of the E37, it's suggested to incorporate more of those HVA risks into the training program. All right, that was the last of the changes. I'm sorry, guys, I hate to do this to you. I know it's a lot to digest and incorporate while you're in the middle of a disaster. It's really difficult. I apologize. I'm available to answer any of these questions that you have about this, but expect these questions to be asked from surveyors. We know they're starting to do the life safety code surveys, and the life safety code surveyors are doing the EP surveys. So we expect to start getting some feedback about these new explanations very soon. All right, let's talk about the infection control after vaccination. I just wanted to mention this because last week there was a question on domestic travel versus international travel and what the restrictions are. And I gave a piece of advice last week, and I said, you wanna, rather than say, if you travel from X destination to here, you've got to go through Y. Instead of doing that, I said, you should probably link to this, and anytime somebody returns back from travel, you check the travel recommendations on that day. Well, CDC moved that travel stuff, and they come up, I don't know why they do this, but they left all of the domestic travel information on one page. That has not changed. That's still the same. But they removed the international travel to a different page. That's linked under that travel requirements. Mostly it's the same recommendations across 4 categories. So they divided up every country in the world into one of 4 categories, from worst to best, or from 4 being the worst and 4 being the most risky and 1 being the least risky. For categories 2, 3, and 4, meaning that most of the world, international travel, when they come back, they're supposed to take a test 3 to 5 days after travel. No quarantine or anything like that. And obviously, if they have symptoms, then we're going to keep them out. But if they're not symptomatic, then it's just a test at 3 to 5 days with no quarantine. And then those in the category, the first category is low risk, do not have to do, there's no testing recommendations. So now this is tied into that CDPH AFL, so we definitely have to follow this. So when it says we recommend a test at 3 to 5 days after travel from one of those 3 categories, countries in those 3 categories, we definitely want to do it. We definitely want to test them. Under the travel requirements, if you know what country it is, all you have to do is click on the country and it'll give you a description of what's the requirements are for each country. So, all right, with that, we have come to the end. I'll see how many questions we have here. It's quite possible that that we see the AFL for visitation tonight. It used to be they would release these things on a Friday evening pretty regularly, so we'll see if they do that. So, all right. What are the current visitation regs for ICF? Well, it's listed out in the AF or the CMS QSO 21-14. Right now, the visitation regs for ICFs are more stringent than they are for the SNFs. We've been advocating really hard for the last few weeks, really pressing CDPH to revise their or incorporate the CMS QSO into an AFL so that we can begin to allow stuff like, out on pass. And now we can allow that now. It's just there's a requirement for those folks to quarantine when they come back. And we're anticipating that if folks have been vaccinated, they won't have that same requirement. That's going to help you guys out a lot. There's a lot of changes that were recommended by CDC that we want to get into an AFL, and we're just patiently waiting for CDPH to issue that. So I apologize. I know they're coming soon. I keep apologizing for something the state has done. I just don't have any control over it, but I'm pushing them as hard as we can to get it done. All right. I don't see the PowerPoint attachments for us to download as we did. Oh, sorry, Terry. Yes, we got two of the attachments uploaded, but the slides will be mailed to everybody that was a registrant. So everybody that registered will get a copy of the slides. Sacramento Air Quality Management District limits our fuel capacity to 72 hours due to our proximity to a school. How can I address this? That's a great question. And this could apply in other AQMD areas that they have a limit of 72 hours due to proximity to any number of other kind of occupancies. I know where this facility is. They're pretty close to a high school, very, very close to a high school. So I kind of understand that, but the reality is you can't overcome that. That's a law. You have to follow what the law says. So your process would say, look, I'm limited by what my local jurisdiction allows me to have on site. This is what my on-site capacity is. This is my process to obtain fuel if I'm on emergency power, and this is when I'm going to activate those plans to be able to get refueled. So let's say if you had a 96-hour capacity, your plan would start searching for those resources to get refueled maybe at hour 48. Whereas if your capacity is at 72 hours, you may say, I'm going to begin looking for or activating those contracts within 24 hours. So that when 72 hours come, I will either have an idea of whether they can meet my need or I will proceed with evacuation. And I think that's the process we kind of have to go forward if you're limited by what your local jurisdiction allows you to have on site. Oh, another question on the slide decks. I promise, guys, we had some technical issues converting it to a PDF, so I'm just gonna send it out as a PowerPoint version to get you guys started. I promise you'll get it soon here. All right, so how do we connect with the local healthcare coalition? I can't find any news on that. Well, if you take my email address, jbelden@caf.org, you send me an email and tell me what county you're in, and I will connect you with the Healthcare Coalition. Now, in Los Angeles County, it's quite a bit different. So if you're in LA County, it's such a large county that we've had to divide up the Healthcare Coalition into DRCs. And the DRC stands for Disaster Resource Center. There's essentially 13 of those disaster resource centers spread throughout the county of Los Angeles. And then about 20 skilled nursing facilities are assigned to each specific DRC. And so when they have their DRC meetings, that acts as our coalition meeting. Right now is a perfect time to get engaged with the DRCs, simply because all of their meetings are virtual right now, so you don't have to go anywhere to attend. So 100%, if you have questions about how to get engaged or who your DRC coordinator is or what DRC hospital is for you, you just reach out to me and let me know. We've got all that stuff listed on our website as well. If you go to the cafdisasterprep.com, on the far right-hand side should be a section that says resources. If you scroll down, you'll see LA County, and it has a list of all the DRCs there geographically put on a map so you can see which ones are where. You do. Can you put a copy of this presentation in the handout? Sorry, guys. Yes, a lot of requests for the handouts. We will get them to you. I promise. I promise. Okay. Just copy. I'm doubling down. You're in LA County. Yes. So in LA County, definitely You have the ability to join the DRCs. The DRCs pass out the same information. It's just the DRC coordinator, that's hub hospital, goes to a larger group with all the folks from the county and things like that. They take all the information from that larger group, which I sit on, CHA sits on, the Clinics Association sits on, all those big hospitals, EMS, public health, behavioral health. We all kind of sit on that OES, all the ambulance providers. Everybody sits on that committee. All the DRC coordinators take the information from those meetings, and then they disseminate it during their healthcare coalitions. For Los Angeles County, in order to respond to bed polling, you got to be on, and situational reporting, you got to be on ReadyNet. There's going to be a free ReadyNet training on June 5th. I will make sure that I put that link in the on the slides for next week. So if you've not signed up for this, this is your ability to learn how to sign up, how to respond to the bed polls, how to respond to the situation report. And it's an hour-long presentation, I think from 10 to 11 on June 5th. So, and I'll definitely get the invite up there. It's free for anybody to attend in Los Angeles County. Well, I mean, it's free for anybody to attend, but if you're not in LA, don't attend it. It doesn't apply to you. So, all right, guys, we've got to the end of our questions. If we have no further questions, I would just want to say, I'm sorry, one more thing about next, well, two things. One, I had planned to have the consultant, the industrial hygiene consultant, come back and present again, but I've actually hired him to do a series of training videos for physical plant staff. It's going to be a 6-part series. We cover some of the stuff that we're talking about in emerging infectious diseases, things like improving indoor air quality, but other things like Legionella and mold and asbestos and other stuff like that that can lead to infection prevention and control complications. So he's a fantastic speaker. I feel really lucky that we have gotten him. So anyways, I couldn't afford to have him come present again here. I had to make a choice to pay him to record these, but this is something that we can keep on our library and you guys can access anytime you get new staff members. I thought it was way more bang for our buck in terms of spending our money. And next week, I will not be here. I'm attending a charity event next Friday, but Deanne Walters and Deanne and Patty are going to present next week. I am certain the AFLs are going to be really, well, I don't want to say certain, I keep doing this, but I'm pretty sure the AFLs will be released next week. So anticipate Deanne and Patty going over those changes with you guys. So hope you have a wonderful weekend. I want to say thank you to Summer and Jamie helping me pull these things together. I'm so technically challenged. I don't know what I would do without them. So I want to say thank you guys. Thank you to all you guys out there. Happy Nurses Week. Happy Skilled Nursing Week next week. Happy Nurses Day yesterday if I missed it. So take care, guys. Have a good weekend.